Marhaba. Hello, everyone. Thank you for joining me to this live webinar. This is Dr. Yassin streaming live from Seattle through PostDIPA, Oral Surgery, Dental Implants, and Periodontics Academy page, and through the Dentistry Online conference page. Uh, Today, I'll be talking about the socket shield technique and cover some of the myths and the realities regarding this new technique that almost everybody in implant dentistry has heard about this technique so far. So to start with, let's start with this main question a lot of general dentists and my colleagues ask me about. What has the shield to do with implant dentistry? Why should we really care about this technique? What's going on? A lot of people, they don't have understanding for the whole technique itself. It's a new technique. It's been published for the last uh, 8 years so far. So we are still building our understanding for the technique in implants. And today, I hope that we're gonna cover the whole idea of what is the socket shield technique, what does the literature say about the technique, steps of the technique, what do we know about this technique so far, and discuss at the end of the presentation, discuss the myth and the realities that we know. Obviously, this presentation is not really is not going to be focusing on teaching the technique, so it's only a brainstorming about what we know, what we don't know about the socket shield technique. To start with this disclaimer, there is no conflict of interest in this presentation, no financial benefit by any sponsorship mean, and all the cases were treated by myself unless mentioned otherwise. Partial extraction therapy, or the socket shield technique, um, is part of this partial extraction therapy, or what I love to call it the PDL mediated ridge preservation. The simple principle about this partial extraction therapy is as long as we preserve the alveolar bone by preserving the PDL itself. So we're trying always to trick the biology to keep the the PDL intact inside the bone so we can preserve the bone. We already know the root submergence technique, which has been described for a long time ago. Submerging a root just to preserve the alveolar ridge, even before the implant dentistry under the bridges. The Pontic shield is another technique to preserve part of the tooth inside or underneath the Pontic just to preserve the bone. And recently, the socket shield, which is associated with implant dentistry, could be related or strictly related to immediate implant placement or delayed implant placement. So the bottom line, whenever we discuss socket shield technique, it's mainly this idea: preserve the alveolar bone by preserving the PDL. If we went back to the literature to see what we know exactly about this. We all know that after extraction, we have dimensional ridge changes. So we have some bone resorption happens all the time after the extraction. It's very famous, Arajo and Lande studies showing how we lose, how the bundle bone will be resorbed after the extraction, and how the buccolingual dimension and even the vertical dimension of the socket after extraction changes. So we've been aware of the changes in the alveolar ridge after the extraction, after losing the intact of the PDL to the bone itself. Back in the 1970s, Dr. Bob O'Neill, my good mentor and friend, he published a papers to submerge of the root for alveolar bone preservation. So people they were aware and they show exactly that this is a method just to preserve the bone around the area of the work. So what they did, they tried to submerge some root. In this case, it was root canal treated, and they observed that the alveolar ridge is already preserved from this. A lot of other studies coming from either Europe or from the US showing that whenever we are trying to preserve the PDL or preserve the tooth, we can preserve the alveolar ridge either by root submergence or even by replantation of teeth. Uh, um, the partial extraction therapy came exactly from this idea. The main idea of the socket shield is to, instead of having extracting the whole tooth itself, we try to separate the tooth into some palatal and buccal sections and try to keep the buccal section intact into the buccal plate, buccal bony plate. And of course, we will deal with the shield, was gonna shield the implant itself and trying to protect any bone resorption, the implant from any bone resorption or bone loss itself. So the original technique is associated with immediate implant placement, and the shield itself, the part of the tooth that is left, uh, is meant to be permanent there. So we're not planning to remove it anywhere. Gluckman and Salama has some two parts actually studies showing step by step and what we know exactly about the therapy so far. It was published in 2017. So let's talk a little bit practical and see exactly what does this mean in clinical case. In this case, actually, I had this tooth number 9, the central incisor, failing. A CBCT is essential actually to evaluate the positioning of the tooth and to make sure exactly we have enough bone. And we will start with separating the buccal aspect of the tooth into the palatal aspect. We usually do some radiographic control during the separation to make sure we are in the same vertical and mesial distal dimensions. After separating the tooth into buccal and lingual, we gently remove actually the palatal aspect of the tooth, and we make sure that we are leaving the buccal aspect, which is going to be the shield down the line, intact into the bone with no stability. And we spend some time shaving the shield and some criteria that I'm going to discuss later on, just to make sure that we have some good prosthetic space for the for the crown in the future. Placing the implant has no difference than the immediate implant placement. We need some initial stability, and we are planning to have a gap somewhere between 1 to 1.5 millimeter between the implant and the shield, which is could be filled, should be filled if it is 1.5 millimeter with bone graft. And we control this. Personally, I control this most of the time with the CBCTs are showing the implant inside and the buccal plate intact, and we can see the shield just protecting the implant itself. And after this, we need to make sure that we are supporting the soft tissue exactly like any immediate implant principle, with some temporary either custom healing abutment or with a temporary crown itself, depending on the initial stability of the implant. So the implant is there, the shield is intact, and it's really stable. We have the bone graft ready. We prepare our mainly, in this case, it was provisional full crown with any method, either chairside or either prefabricated at the lab or the digital implant dentistry or any guided surgery. And the main goal is just to use this crown to support the soft tissue around the implant. So let's go a little bit backward. This is the technique. We are aiming to leave part of the tooth intact into the buccal plate and trying to leave it there so it can act as a shield protection into the implant, hoping that is going to preserve the bone and preserve the even the soft tissue, and supporting this actually with what we know from the immediate implant placements with some temporary immediate temporization. And we all know whenever we have a failing tooth, we have two different options, either to do extraction, ridge preservation, and delayed implant placement, early delayed, uh, or to do immediate implant placement with or without provisional prosthesis, which we have enough literature to support. And we know that the immediate implant will provide us with fast method, less painful, less surgeries, tissue preservation, either bone or soft tissue, aesthetics, and it's predictable. So in the literature, we already have, since the 1990s, we have enough papers describing that, like Reader, describing that the immediate implant and immediate restoration appear to be a viable alternative to early implant placement. An experienced surgeon is trusted with the implantation procedure. Uh, Can and a group from Loma Linda University always show that it's high predictable to have an immediate implant with immediate provisionalization into the anterior teeth, and they showed a lot of successful long-term studies for this. In the ITI treatment guide, Boozer and Chen, they described actually the low and high risk of doing immediate implant placement, starting from getting low risk if the patients have low aesthetic expectations, low lip line, low scallop and thick tissue biotype, and the shape of the tooth rectangular. And it's high risk in their studies if the patient is a heavy smoker, which is more than 10 cigarettes a day, and the patient is with high expectations, the lip line is high, it's thin biotype, or the teeth are triangular. Um, Down the line, we developed actually some understanding, and we had some consensus actually about the immediate implant placement. And we all know that whenever we place an immediate implant, we need to engage the implant into the palatal plate, leaving a jumping distance somewhere between 1.5 to 2 millimeter, actually, trying to avoid any engagement into the buccal plate and make sure that we have a good restoration. This beautiful, demonstration is from my friend Francisco Barbosa. I thank him for letting me use him. And then Can et al. In 2003, starting from 2003 with Lozada, actually, they started to make a classification actually for the um, teeth positioning inside the ridge, the alveolar ridge. And they just divided this into type 1, which is well, we have the tooth engaged actually in the buccal plate, and we have enough bone in the palatal which we can put our implant in, and it's the favorable to place an immediate implant. We have type 2, which is the tooth will be in the middle, so we don't have enough bone either or. Type 3, we have the tooth engaged into the palatal plate with only possibility of engaging the implant in the middle or on the buccal plate, and type 5, which is not a good option to do an immediate implant. So we have understanding for immediate implant, and whenever we do socket shield, we need to make sure that we are doing the same principles of immediate implants with the socket shield. So what's the long-term predictability of immediate implants? We've been doing this long enough and we've seen a lot of success. Let's talk about this quick case here. We have a tooth, it's a type 1, it's good for immediate implant. We did a traumatic extraction. I used here the Benex machine. I love it actually. And then we do the preparation into the palatal plate, placing our implant. We have the jumping distance at 2 millimeter. In this case, I followed the surgery veneer grafting for uh, Agnini brothers, and we used the connective tissue graft to support actually the buccal aspect of this, using the immediate provisional custom healing abutment here to support the soft tissue. And down the line, we can see that we have soft tissue stability here. So we use the bone graft also in this case. So extraction of the tooth, the provisional custom healing abutment. After 4 months of the implant placement, we have stability in the tissues, and even after delivering the final crown, this picture is 1 year after delivering of the crown, we still have some stability actually of the soft tissue in general. So we have high success rate in immediate implants, but the fact is we still have some issues with long-term prognosis of immediate implants. We have some recession, gingival recession, and who practices implant dentistry knows exactly that we have this problems either by losing soft and hard tissue, exposure of the threads, some of the buccolingual loss of the bone width. And for this immediate implant, we followed this for 3 years, and we had a big, huge bone loss at the buccal plate of the implant. So we have some issues in immediate implants. That doesn't mean that immediate implant with the traditional ways that we've been doing is unpredictable, but we see some long-term issues all the time. And this is actually proved by the literature. Uh, we have labial bone remodeling, we have bridge collapse, tissue recession, color changes, implant stability, buccolingual collapse, gingival recession, and loss of the papilla. Can from Loma Linda again, because the group is big in immediate implants, they followed actually with a lot of cases for long term, and they saw a lot of those problems just occur with the implant placement. The Rogue actually, this is one of the studies that I love, single tooth replacement in the anterior maxilla by means of immediate implant and provisionalization. They showed that we have some issues, especially with poor case selection, and we need to have strict guidelines for immediate implants to bump the success rate higher. So the long term has some question marks and immediate implants, especially with the aesthetic zone. And as I said, we have some evidence-based data showing that we have a lot of recession. Some of the high demand aesthetic demand patients, they are showing either metal or the titanium around the implant. So we have issues around the implant. We've been understanding this for a while. Because of this, we can see through the literature, Filippi et al. Actually in this paper, they described the decornation of the ankylosed tooth for preservation of alveolar bone prior to implant placement. So it's the same idea. We have an ankylosed tooth. We can try to preserve the tooth to preserve the implant. So down the line, we can do to do an implant and a good preserved bone. And it's not really a new idea. We've been doing this in oral surgery aspect for the coronectomy, for example. Not only in the goal of preserving the ridge, but we know that leaving partial extraction for third molars, which is engaged with the IAN, the nerve, with high risk of having paresthesia or full anesthesia actually after extraction. We do partial extraction and we leave vital roots underneath the ridge. And we know it's evidence that we can leave vital roots into the area, and of course, eventually, is going to preserve the alveolar ridge. The socket shield developed exactly from this idea, trying to jump over the immediate implant issues that we have into tricking the biology with leaving part of the root of the tooth actually as a shield. And this is called socket shield technique. The partial extraction therapy, as I described, it's combination of everything of root submergence or pontic shield. And for myself, I like to say it's PDL mediated ridge preservation. We are trying to preserve bone through keeping the PDL intact around. Uh, and as I mentioned before, the socket shield should be protecting the implant, and we'll talk about a lot of criterias and some misunderstanding and some realities about this down the line. In 2010, the first one who mainly reported the technique is Husler and Zur, actually from Munich, Germany, as a proof of principle. And mainly what they did very nice animal study, and they used the endogain actually in this case to to study the possibility of having a successful implant placement to the palatal of the shield, of the buccal shield that they say, and they concluded, and in some human cases actually, retaining the buccal aspect of the root during implant placement does not appear to interfere with osseointegration and may be beneficial in preserving the buccal bone. So they are confirming what we know, but they are just bringing to the table something that it's really becoming so interesting so far. That's a lot of information. We're talking about in dental implants. Everybody who was trained in dental implants knows that we need to do extraction, we need to take the whole tooth out, and this is a lot of question marks here. Now we're talking about leaving one portion of the tooth and put the implant next door. It's a nice idea. Does this technique work for real? A lot of people, they will hear this for the first time in this presentation, and I'm sure that too many people, they know exactly what I'm talking about. And I have growing number of friends and implantologists and dentists all over the world. They already have tried the technique. So let's talk a little bit in more details about the socket shield technique. As a surgical procedure, again, just to make sure that we understand the steps to do the technique. And again, this is not really a training presentation. It's just to either you don't know the technique, so you know exactly what you're talking about, or you have an idea, so you have some evidence base in the literature to apply to your practice. Um, or you have some discussion to agree or disagree with whatever we talk. This patient came to me and she had some previous dental implants with some recession, so she was not super satisfied with dental implants. So she has this premolars failing, and through the CBCT we have very thin buccal plate. It is intact. We could see that with the extraction, we're gonna change the socket type from type 1 into type 2 or 3. So we discussed to go with a socket shield technique, trying to grind the teeth down and make sure to prepare our socket shield from with the mesial distal cut to preserve the buccal plate, the buccal aspect of the tooth itself. And as I said, I do always some radiographic measurements during the surgery just to make sure that I have good dimensions of the drilling, especially with the sensitive area in the mandible and with the proximity to the IAN. After preparing the cut, we just remove the lingual aspect of the tooth. We make sure that we're cleaning everything. We're removing the pulpal tissues. We are not leaving any gutta percha or any pulpal tissues, and we make sure with our measurements that we already removed everything, including the apex of the tooth itself. And after this, we have like raw shields. We need to spend some time just to make sure we are reshaping the shield itself, placing our two implants with good initial stability. In this case, I added another implant in the molar area in the back, and we could see that from the extraction that we already have some buccolingual bone resorption, and we already lost some bone contour actually. The socket shield is meant to be a flapless technique we are trying to preserve, and it's a big discussion we're gonna have down the line also. But this is the final result in the area, and we can see in 2 months that we have three implants. The two implants that have the socket shield, they are preserving the buccal plates, preserving the tissues, and we can see that we have an intact um, um, seal actually in the gingival margins. We could see some bone graft material here as we already utilized the dual zone technique described by Salama and Tarnow. And a 6 month down the line, we still have our two implants, very nice tissues, very nice buccal aspect protecting the shield, protecting the implants themselves. So we have no issues with this to proceed with restoring the implants with good and nice tissues. It's mainly made better than the molar in the back because we have very nice and protected buccal aspect of the implants, very natural. We can see the difference between the, before the extraction and 6 months post the extraction. We still have the same thickness of the ridge, and the implant are supported. We are not expecting to have any, resorption or any alterations in the ridge width. Uh, So what do we know about this new technique? And we see everybody's talking about this partial extraction groups, and everybody's trying to uh, utilize this technique. How predictable is the socket shield technique? It's a big discussion. Whenever you go and somebody's doing the socket shield, either agree or disagree. So I wanted just to summarize what we know here to the audience and say, hey, what the socket shield technique? What do we know? What are the myths and the realities about this technique? What the majority of people believe about the technique, which is not true sometimes, and what are the realities that we've been building for a while, since we've been trying the technique for almost um, 8 to 10 years. Personally, I've been doing it for 3 to 4 years. I have tens of cases. So let's start with the number one myth about the socket shield and see how it goes. Myth number one: socket shield technique is unpredictable and has no evidence-based data behind it. The reality is many studies show that the socket shield technique is predictable with high success rate to the best of our knowledge now in 2018. We have some long-term studies, and we already have we have 5 year studies published, and we are almost ready to get 10 years follow-up of the studies. Balmer actually, from the Husler group from Munich, actually, they published this in 2017 about the immediate implant placement. It's a clinical, radiographic, and biometric data after 5 years. They studied actually several cases, in human cases, and they showed that we have stability in the buccal tissues after 5 years of the socket shield technique. And they mentioned that this technique needs more high evidence studies to support what they found of predictability and the stability of the tissues itself. Uh, Glugman actually, Salama, and Dutoit actually from South Africa, and of course my good friend Maurice Salama. They've been doing this for long enough to have some 128 socket shield to publish and show exactly what works and what doesn't work in the technique, showing what do we have complications with them and what is they followed up some cases all the way up to 4 years, and they concluded actually that the comparing to the implant survival rate, the socket shield technique is really high, and it's similar to the success rate. And of course, they are mentioning that we need more high evidence researches about it. So the proof of the principle since Husserl and Zur actually back in 2010, they've been keep going actually with some data. Um, um, Recently, uh, Greek group actually, Mitias and my good friend Kotsakis and some friends, they had a chance actually to retrieve one implant from their socket shield cases after he had an accident, unfortunately, and they had a human histology showing how the integration between the implant and the bone, even with the presence of the shield. So we can see how the bone is just creeping around with high success rate, successful integration. So this is after 5 years of function, and they're just showing we have success integration. Personally, I'm very proud of this case. I had like this split mouth with this patient. I had this premolar number 5 and the other premolar number 12. Both we did immediate implants. Number 5, I did the socket shield around it, while on the number 13, I had just traditional immediate implant. I just put the bone graft. I did not put any soft tissue or connective tissue graft. And the result here, after 6 months, we can see how the socket shield already preserved the implant, protecting it from any resorption, while here we have some buccal alteration going all the way down. And as we discussed before, we have this problem. So, and maybe down the line we will have some more, recession in the soft tissue around the implant itself. Does that mean that this one is not a success? No, it's functional, it's good, but if it is in the anterior area, we'll have other bigger issues, as we discussed already about the immediate implant and its issue. So we have a proof of principle that the socket shield technique is working really well. On the other hand, um, we have one systematic review trying to cover all the studies that have been published actually about about the socket shield itself. Amit, my friend Garpur, actually from India, they published this systematic review, and they reviewed mainly 23 papers, and they concluded that the socket shield has a high failure rate. And unfortunately, the study is too early to have systematic review at this point, especially with all the cases have been published only as case reports or case series, plus the power of the study as a systematic review here, with a lot of papers coming from non peer-reviewed like journals, is questionable. But we are open to have more studies showing the predictability of the socket shield technique. We all need the reality, right? The myth number 2: complications may arise before retrieving the shield post-implant integration. A lot of people asking me, how about removing this piece? Are we going to have any problem before removing this piece of shield or the buccal section of the tooth itself? The reality is the socket shield is permanent and must be designed to stay intact and will not be retrieved. So we already know that we are leaving this shield intact to the buccal plate. So we are keeping this, trying to protect our implant, trying to preserve the bone around it. Also recently, Chuck Schwimmer had a chance to um, publish a paper. It's a human histology. One of the implants failed, and we had like unintentional left tooth there, and he showed that we have no problems actually with putting an implant next door to the dentine actually, and the bone will sneak around the implant and will have better integration. It's not going to integrate with the dentine, but it's integration with the bone itself. And as I can show you here in one of my cases, this is the implant. We have bone, we have the socket shield. This is one of the cases that I did only healing abutment on this. I did not do any custom healing abutments. And we can see that the gingival margins, they are just growing over and sealing around the implant and perfect preserving of the buccal plate. So the shield is already designed to be left there. We are not removing this. Myth number 3. Leaving part of a tooth is a high risk of infection, implant integration failure, and migration of the shield. As we discussed before, many old and new studies show that with proper case selection, it's safe to place implants next to a stable tooth fragment. And this is the reality. It's something old, it's nothing new. Boozer and group, actually, since the 1990s, they published a paper showing that, it's an animal study showing a formation of periodontal ligament around titanium implant. No interference actually with the implant functioning and or the rest of the osseointegration of the implant. They suggested in this paper that maybe this is something new for the regeneration, and maybe we'll have similar attachment between the implant and the bone, similar to the natural tooth. So the summary of the study, that we don't have failure implants coming from neighboring a root there. Gray himself, another animal studies, showed that, talking about the interference between retained roots and the dental implants, and it's also a histology study, animal study, showing that the unintentional placement of dental implants did not result in any inflammation and may have produced cementum or cementum-like matrix. So as we can see, the implant is here, the alveolar bone around, the root is there, and we have some of the PDL sneaking around. And they showed in the bigger, magnification, they show that no inflammation at all, we don't have bone resorption, and the implant is integrated just fine around it. Langer also, they very nice study. They discussed the unintentional root fragment retention in proximity to dental implants, and they discussed the literature, what we know about this, and they reported 6 human case reports. And obviously, they said whenever we have good conditions for the left root dentin inside the alveolar bone with an implant neighboring it, we'll have no inflammation. We'll have some issues if we have some infection or some mobility of the fragments. So they were very realistic with prescribing what they're seeing, what they're seeing. And we all know that whenever we need to leave, even with extraction, if we have any mobile fragment of the tooth, it's a must to remove it. So this will be exactly the same in the socket shield. Stability of the shield is a key of success. In this case, for example, I was planning to do a socket shield neighboring root submergence, and everything went fine. This is one of my very first cases. We did this root submergence and prepared the site for the implant and placed the implant itself. In this case, you can see that the implant is very close to the shield, and personally I believe that whenever I tore the implant down, we had destabilized actually the fragment and the buccal shield itself. Luckily, I discovered this before finishing my surgery, and I saw mobility in the shield, and we have to be very strict with this. No mobile shields should be left behind. And taking the decision of removing the shield after mobilization should be just as piece of cake. We just have to remove it. We have to change the whole plan from socket shield technique into traditional immediate implant. And in case we had not very good conditions for an immediate implant, just change the whole treatment plan into some delayed implant with ridge preservation and bone graft. The myth number 4: disadvantages of the socket shield technique exceed the benefits. As I said, we've been doing this for 8 to 10 years, and we are still building our understanding. We are showing a lot of success. But the reality here that socket shield technique has many proven advantages and, like any other new technique, some disadvantages. And let me go through some of the advantages that we have been seeing actually about the socket shield. First, control the resorption of buccal bone. Second, provide soft tissue stability. Less grafting of soft and hard tissue. Less traumatic and hard extraction cases, and if we have any ankylosed tooth, instead of destroying the bone for the extraction. Reduce number of required surgeries. Preserve the nature and the blood supply, trying to do everything flapless around it. Less pain and morbidity for patients. Short treatment and healing time, and a lot of time will going to be cost-effective treatment for the patient, considering that we might need to add a lot of bone graft or soft tissue grafting down the line and implants. And clinically, when you mainly try it, you can see the advantages of this. One of the cases that I've done, a patient came with a central incisor number 9, it's failing, extraction, socket shield done, temporary tooth delivered on the same time, 12-month post-operation. We can see very beautiful gingival margin, very beautiful buccal tissues, soft and hard tissue. We have stability, or even we gained some of the gingival margin here, and you can see from the occlusal shot that we have exactly the same natural peak of bone still preserved around it, still after 12 months of post-op. And when you remove the temporary crown itself, you can see that we have a very nice shape actually of the gingiva, and the sealing around the implant is just good. So I think this is the ultimate goal of the aesthetic implant dentistry: try to preserve the nature and try to mimic exactly what we have with less surgery and with less invasive procedures. So this is the biggest advantage as we can see it directly in those kind of cases. Let's talk about the myth number 5. There is not consensus regarding the optimal standards for successful socket shield technique. Apparently, whenever you sit down with a socket shield fellow, you'll have a discussion and you can agree and disagree, and which is fine. But the reality is, clinicians from all over the world have been building their understanding for the socket shield technique parameters of success. And for example, last year in November 2017, a bunch of people, they just joined Jorge actually in Madrid, and every single one of those dentists actually they've been doing socket shield for a while, and they know exactly what to discuss, how to discuss. Of course, it was a successful meeting. Unfortunately, I did not have a chance to join them. Down the line, we have some fellows like Maurice and Howie. They've been doing the socket shield, and they are open about their success and failure. They are open to discuss what's working, what's not working. I was fortunate enough to have this big discussion this February, actually, in this month, talking about the partial extraction, which personally I learned a lot, and we had great discussions, and we had this big debate of implant placement with Maurice, Howie, Dr. Boozer, Dr. Tarnow, Belzer, and Stephen Shu, Dr. Zada and Garber, big names, a lot of people. They've been doing implant dentistry either at the surgery side or the restorative side. And I was fortunate enough to see this debate and discuss not only the socket shield, discuss the early delayed implants with the GBR, the ITI group, PAMOS technique, and the immediate and dual zone therapy with Dr. Tarnow and his prosthodontist, Dr. Shu. But anyhow, so from all those meetings, I think everybody who's doing the socket shield had some understanding. First of all, of course, we need more studies to show the success. But we have some parameters that everybody has agreed on, and some of them are negotiable, some are non-negotiable. I'm going to try to summarize things just for the sake of um, um, the discussion itself. First, stability of the shield is the key of success, as I said. Nobody should hesitate at all just to remove the shield if we have any mobility in the shield. Removal of the apex is essential. We don't really need to have any apical, tissues left behind. No fracture in the shield, although that Bomber and Husler, they showed a vertical fracture case report, but also the observation that whenever we have fracture in the shield is going to be more problematic than having an intact shield itself. Custom healing abutment or provisional crown, it's the same standard as an immediate implant. We're trying to support the soft tissue, the gingival margins. So we are leaning toward having a custom healing abutment or provisional crown depending on the initial stability of the implant. Implant level should be at the shield level or a little bit down. So, and this is a big point of discussion, but in general, we don't really need to have an implant above the shield. We need to think and the restoration, the finer prosthesis also. Confirming the prosthetic space is a very early skill that we need to learn. Personally, myself, I try to use an abutment during the surgery or try to see my crown or the custom healing abutment. I try to confirm that we have this buccal area of the shield. We have enough space to build your emergence profile in the perfect way. Filling the buccal gap with bone graft, I think it's also one of the immediate implant parameters that we've been aware of. Definitely more research is needed with high level of evidence so we can build better consensus about the socket shield itself. The myth number 6. Shaping and positioning of the socket shield is irrelevant to the success rate of the technique. Meaning, like, you can just leave whatever section or whatever part of the root attached to the buccal plate and just to your socket shield. And the reality, it's not. Proper shape and position of the socket shield is key to the success rate of the technique. So we need to spend some good time on reshaping and repositioning the level of the shield itself. I was during my this presentation preparation, I was aware of this study. It was published in February 2018. It's an animal study coming from Tan et al. Actually, and they concluded, they're a very nice study. They concluded that the height of the root segments has little effect on bone absorption of alveolar bone, and we're talking about the socket shield itself, while the bone absorption was strongly influenced by thickness of the root segment. More precisely, the absorption may decrease and the thickness of the root fragments increase. And mainly they are recommending the thickness at least 0.5 to 1.5 millimeter in range. So let's talk a little bit about the shield. So it's important to know. And there are some parameters that a lot of people they agree on. First, we need to have a C shape of the shield, and starting uh, um, from angle to angle all the way to mainly cover not only the buccal plate trying to hold the implant, pushing the envelope a little bit toward the proximal, distal, and mesial. We have a famous study coming from Can et al. From California, and they tried to do proximal socket shield, trying to preserve the papilla itself, which is totally different story. We're not talking about it in this presentation. So C shape of the shield is very important from line angle here to line angle here. 2/3 of the buccal aspect of the root should remain, and as we can see, implant should be placed, and 2/3 at least of the shield should be intact with the buccal plate. The main thing here, actually, we need to pay attention to remove the apex itself, as we discussed, and personally, I think more contact between the shield and the bone itself, more PDL surface will provide us with more stability of the shield. A big question always asked, like, what's going to happen with the shield? And we're waiting for more studies or more human studies to show us exactly what's going to happen. Personally, I always say if we don't have clinical issues, I don't know if this shield is going to be resorbed, but we need to see more clinical success, more studies to show exactly what's happening of the shield. As long as it's stable, I think it's going to be good, exactly like I showed in the literature. Implant depth should be at the shield level, and as I said, maybe we need to pay attention to the prosthetic space here. The implant could be a little bit more apical to the shield, but the consensus that is absolutely not going to be above the level of the shield itself. Still going with the shield shaping, implant does not touch the shield, and we have two different issues here with implant touching the shield itself. At the very beginning of the technique, when first described by Husler, and a lot of modifications came through, we did, a lot of people, they reported that we can touch the implant into the shield, as you could see in the two different studies coming from either Schwimmer recently or Mitsias from Greek, actually, with touching the shield itself. Personally, I feel, as I showed you one of my cases, whenever you are touching the shield, you are getting high risk of destabilizing the shield itself, which is whenever we have a mobile shield, it's going to be just higher rate, failure rate, or possibility at least. So let's deal with the socket shield technique exactly as if it is immediate implant, and keep some 1.5 millimeter of jumping distance, and discuss later if we want to put some bone graft or not, and have a discussion of what kind of bone graft. Is exactly the same discussion that we are having, or we had before, for the immediate implant placement. The shield prepared to bone level. So this is another discussion. Where should we put the shield at? We already agreed that we want to put the implant at the level of the shield, or at least more apical to the shield. But what's the level? What's the vertical level of the shield? Some discussions will say let's put the shield a little bit above the bone level to provide more support to the gingival margins. And actually, from my experience, whenever we are putting the shield above the margins, we will get more complication as external exposure or internal exposure. So the consensus actually is to put the shield on the bone level, trying to preserve the bone itself by the PDL preservation, and we will support the soft tissue by our provisional custom healing abutment or crown, exactly like we do in immediate implants. Create a shape for prosthetic space. As we could see, we have the implant, and we need to make sure that we have enough space for an emergence profile to have better understanding or better support to the soft tissue. And the thickness of the shield, as this recent study showed, we need to have it 1.5 to 2 millimeters thickness of the shield. Is the thicker, the better. Technically and practically, I think 1.5, 1, let's put it this way, 1 to 2 millimeter of the shield would be sufficient enough. And remember always, we need to have the shield stable as we can. The myth number 7, it's the myth um, uh, before the last one. Socket shield technique can be done in every single extraction case in implant dentistry. And this is unfortunate statement that I see a lot of younger dentists, fresh graduate dentists, or very beginners actually in implant dentistry. They are trying to apply whatever they're seeing through the social media, or trying to apply whatever they're seeing through the internet into their practical life. The fact is, socket shield technique must be done within strict case selection criteria. We need to know exactly that uh, we have some points that we need to make good diagnosis before jumping into the socket shield procedure itself. We have to have intact buccal bone. We cannot really leave a shield just attached to a soft tissue without a bone around it. The main goal is to preserve the bone through the PDL intact, contact with the bone itself. No tooth mobility. We don't really do anything with periodontitis or like mobility of the tooth, because it's gonna be affecting the mobility of the shield itself. So no periodontitis, no active infection around the tooth, and always we need to consider the restorative space, and especially in molars area. Personally, I have not done a lot of molars socket shield. I've tried several. I always have this big question about how to do the buccal space, restorative space, with two different big two roots in the buccal. So we need to choose our cases wisely in the socket shield technique. And remember, we have two different techniques. Either to do the socket shield as an immediate implant, and we decide this, um, hopefully before the surgery, but we can change the plan always. So the first plan is to, the first option is to do a socket shield immediate implant with immediate provisionalization itself. In this case, I did the socket shield flapless. Also, to make sure that I am seeing the shield, seeing the bone, and I'm shaping the shield in a better way. Or they have the other option. If we have any issues, we can do stage as described by Glocker et al., which we can do the partial extraction, leave the shield intact with the buccal plate, and graft the socket exactly like ridge preservation. Come back in the future and do the implant down the line. So we have two different options. Usually the socket shield is associated with immediate implant, as discussed. The myth number 8, which is the last one, the socket shield technique is an easy procedure with little to no complications expected, which is a little bit too much myth, but a lot of people, they feel this about this new technique. And we are in an era that we are exposed to everything, especially through the internet, exactly as I'm reaching you right now, from my little home to everybody's home. But people, they are seeing things over the internet, over the social media, Facebook pages, groups, and they are trying to mimic or try to apply this. The reality here is the socket shield technique is a very technique sensitive procedure with possibility of complications. So we need to be aware of the literature available about this. We need to have um, um, some good training about it, and we need to know those points. The technique, the socket shield technique, is very technique sensitive and require adequate training. So going through some courses for training is something essential to succeed. Special instruments and armamentarium is needed actually. So when I first started my socket shield career, actually, I tried to have my long drills, burrs, and And honestly, you need, whenever you have a single tooth and you have adjacent crowns around it, you need some good length to first do your cut sharply. Make sure that you have a stable shield. You don't really destabilize it, and protect the gingiva. So we have some instruments should be available, which will make our life easier, of course, and will bump the success rate higher and make the procedure as fast as possible. High magnification is highly recommended. So either you have your loops mainly, or the microscope itself, which is going to be better in a lot of cases. And believe me, the case that I showed that I saw the mobility of the shield, I saw it through my microscope. So magnification is something very important. One of the key point here is to have a three-dimensional CT scan, the CBCT, beforehand. So I do believe that every single socket shield case uh, before the performance of the implant on the socket shield, we need to make a good diagnosis, go back to the principles, immediate implant principles, know exactly what type of tooth positioning we're dealing with. Are we type 1, so it's favorable, or it's type 4, which is not really favorable for this. Training the restorative team from lab to dentist, restorative dentist, talking about the idea with my colleagues, my prosthodontist and my general dentist team about when and how to make the temporary teeth, how to build the emergent profile, how to support the soft tissue, and how to fabricate your final restoration. Um, as I said, the technique is not really designed for beginners in implant dentistry. I think anybody with advanced level in implants should start the technique with one root tooth. So it's not recommended to jump into molars directly. So remember, we're still building our better understanding for the whole technique. And remember, always complications may occur. And the study that I discussed from Gluckman and Salama and Jonathan Dutoit, actually, they prescribed 128 socket shield cases, and they showed actually the failing cases, um, not necessarily a poor selection, or but we have some manageable complications and some other complications that we can't manage. Complications may be internal exposure of the root, which doesn't show that the shield is failing or the implant is failing. We can do some trimming actually to the shield and try and give the chance for the gingiva to regrow around it and seal the implant itself. We have a possibility of implant failure, exactly like the implant failure rate and immediate or delayed implant dentistry. Uh, the shield failure sometimes happens, especially if we are not really so aware of leaving an apical, tissues, or if we have any stability, some mobility of the shield. And a lot of time removing the shield, leaving the implant, and changing the whole technique into some GBR, some bone grafting, would just work fine. Or external exposure here, which is go exactly to the internal exposure concept, that we can trim the shield and give the gingiva a chance just to heal back over the shield, protecting their implant itself. So this is about the socket shield. I hope it's a lot of information. I try to cover the basics. I try to cover the literature, what we know, what we don't know. Um, I know every single buddy in the group of the partial extraction therapy group. They know that we have proof of principle about the socket shield. It works in a lot of people hands. We know that we have a lot of unexperienced, like less experienced surgeons, that they're been attempting to do this, which will bump up some of the complications or failures. So the take-home message actually for the socket shield technique is socket shield technique is reported to be predictable therapy so far, as we know from our case series studies. Um, we see a lot of stability, and as I said, we have already put like 5 years data published, and we're looking to have the 10 years data published soon from Greek group, Mitsias and al. Uh, the second point is long-term studies and high evidence level research are needed to support the proof of principle of the socket shield. We have this systemic review, which is, I do believe we have some question mark around it, but we need more maybe clinical trials, randomized clinical trials to see. And we encourage everybody just to participate and share the knowledge with everybody for better understanding. Case selection is crucial. We need to know when to perform socket shield, when not to perform socket shield. Technique sensitive and require advanced level in implant dentistry. Remember always you don't really need to do the socket shield technique maybe in your first 100 implants. You need to understand exactly the biomechanics of implant dentistry before attempting the socket shield. You cannot really do socket shield without attempting immediate implants, regular ones before. So take it step by step, and remember everybody in the partial extraction therapy is here to help. Finally, I hope that I covered everything. I would like to pass a big regard to the friends and the partial extraction of Howie Gluckman, Maurice Salama, Henry Salama, and Jonathan Dutoit. And I hope everything is covered in this. It's just a trial and as a socket shield technique to be covered and in general know exactly what's the advantages, what we know, what the literature, and then this is my email address. If you have any questions, please don't hesitate to contact me. Thank you very much for your attention, and we'll keep in touch. Have a great night.